Welcome everyone to the Teen and Young Adult Hip Dysplasia webinar from STEPS Charity. I'm Jacqueline and I am a volunteer for STEPS and also a parent of a child with DDH. Our guest tonight is Holly, who created a fantastic leaflet about hip dysplasia in teens and young adults. Holly, I will hand over to you to introduce yourself.
Hi everyone, I'm Holly. I run Hip Dysplasia Physio. I also work as a hip advanced practitioner at Cambridge University Hospital, and I myself have had a hip dysplasia journey. So one of my biggest passions is helping everyone on a journey with dysplasia, helping clinicians diagnose dysplasia. So thank you for having me.
So today we're going to go through some of the questions Holly has presented in her leaflet for the live audience, and you can send questions through as well. The first question is, what is hip dysplasia and how does it differ from development dysplasia of the hip, DDH?
So hip dysplasia itself is a maldevelopment in the size, shape or orientation of the acetabulum, which is the socket of the hip. Traditionally, it used to be called congenital hip dysplasia, and we always thought that it happened at birth. But now, in more recent research, we understand that it's not only present at birth, but can develop as you grow. So developmental dysplasia, it's the same as hip dysplasia, but it encompasses more babies and children, whereas then we term hip dysplasia more for skeletally mature patients into later teens and adulthood. So that's the only difference between the two.
Okay. What makes the hip joint stable? What does it look like? And what's different in hip dysplasia?
So there's three things that stabilize the hip joint. You've got the bony stability. So you want a nice coverage of the socket and the acetabulum within normal parameters. So a normal lateral coverage would be 25 to 40 degrees. And then also where the bony shape is. So is the socket roof quite flat? Or you can look at an angle called acetabular index. Does the roof tilt up and therefore the ball can move up? So that bony stability and those bony parameters need to be within those correct parameters. The acetabular index needs to be under 10. The next thing that stabilizes the hip is then the ligaments and the capsule. So they're another passive stabilizer. And we know that in hip dysplasia, 50% of patients have hypermobility. So they may therefore have a more lax capsule, more lax ligaments that's around the hips. And then the last thing that stabilizes is the active system. So that's the muscular system. So if you've got compromise in that bony stability and you've got a shallower socket with lax ligaments, you can get more shearing going on in the joint and more interplay. So the muscles have to work harder to try and stabilize that joint. So having really strong muscles is really key in hip dysplasia to try and reduce that instability and that shearing.
Okay. What are the common symptoms of hip dysplasia in young adults?
So it's quite common that you get a gradual onset of symptoms, often starting with groin pain or anterior hip pain. That can also be lateral pain and kind of overload pain with lots of activity. And you can also get associated pains like back pain, knee pain, and pains elsewhere in the body. And there's often a link with night pain as well. It can be up to, so there's a study from 2011 by Nunley et al., and it was up to 67% of patients did report some night pain. And then you also get mechanical symptoms. So patients often report clicking, catching, locking, and giving way. So instability signs that the hip can really give way on them, or it clicks and clunks. Now that can be the labrum, but it can also be psoas itself, so one of the hip flexors. And a lot of patients on their journey are often diagnosed with hip flexor tendinopathy and treated for that when actually it's dysplasia underlying that's causing the issue. So the last symptom that can often be there if it's kind of a long journey is early arthritic symptoms. So obviously you see a lack of joint range of motion with early arthritis. But But on the flip side, if patients are really hypermobile, then you can also see a gross increase in that joint range of motion. So they may have really unstable hips, and the rotational profile can move through a huge range compared to the normal average person.
Okay. Who can this condition affect?
So as we discussed in the first question, obviously hip dysplasia can be present from birth, through infants, through teen. It develops, so we don't know always whether it's been there from birth or it's developed as a patient has grown. So anywhere along that pathway, you can be diagnosed with hip dysplasia. Obviously, the ideal would be that, we're catching it early on as they're developing as babies, but it is also more common in women. And athletes, those who do high-level sport or are very, very active, often report that they notice the pain coming on earlier and their hip fails earlier. Whereas if you're less active and less loading of your hip, you tend to fail later on in life. But that isn't always the case with every single patient.
Okay. Does it run in families?
So yes, there is genetic predisposition, but it is multifactorial. So there is a genetic link, and heritability is about 55%. But there also is environmental factors that can cause the prevalence. So things like firstborn, female, gender. In studies, there is hip dysplasia in men as well, but you're 4 times more likely to have painful hip dysplasia in female patients. And again, that's multifactorial itself. Breech presentation as a baby is linked to hip dysplasia, and then swaddling as a baby as well. So really ensuring that any swaddling is done now just in the upper part and not having the legs in a straight position, so the legs and the hips are free to move and abduct. So it's those environmental factors that can then have a strong interplay with the genetic factors as well. And then there's lots of studies ongoing at the moment looking at, it used to be linked to one gene, and now there seems to be quite a variety of genes that it's being linked to. And some of those are linking the sort of malformation of the socket, and some also with the cartilage development. And there's some studies that are showing that, if you have the better cartilage genes, then you're less likely to develop OA and the arthritic patterns, especially if you can get away with it in like a milder form of dysplasia. So it's quite an interesting interplay, and we don't know the whole answer to that.
Okay. How is it diagnosed?
So it's often, sadly, a very long journey, and it shouldn't be. So that's the thing that we need to change. So a really good subjective history, even your GP should be able to pick this up. And a subjective history, talking about all the things that we just spoke about the common symptoms. They should be asking those sorts of questions. Family history as well is a key one to ask. So anyone in the family had early hip replacements, exploring those presentations as a baby. So were they a breech presentation? Did they have issues with, nappies and hips not opening correctly when they were younger? So I explore those even in my teens and young adult patients when they come in, especially if the parent's there. When did they walk? How did they walk? Have they ever walked in towing or out towing? And then you want to do a really comprehensive exam, so including, functional movement, squat, balance, single leg squat, heel raise, looking at their biomechanical control, looking at then range of motion, looking if you're seeing that massively increased range of motion in the rotational planes. And you would want to look at that in both in flexion and in extension. And then also looking through palpation through all the muscles and the tendons, because you get a lot of associated muscular tendinous pain in different areas around the hip when you have the dysplasia. So as well as I said, iliopsoas tendinopathy, a lot of patients get lots of lateral hip pain, struggle lying on their side, pain at the side of the hip on the bone. And that's because of overload through the gluteals, because of the the shape of the socket and the way the gluteals are overloaded to try and support the hip. Strength testing is also key, so looking at muscles that are strong, weak, overloaded. We often see that the more superficial muscles tend to take over and the deeper ones tend to waste away. And so, you know, a pattern I see tends to be that tensor fasciae lata, a muscle at the very front side of the hip, tends to get bigger and bigger because it's taking over for the glute med at the backside part of the hip. And I see that can become quite large and quite tonic, so it's on all the time and can be quite painful itself. And it's cheating them for some of the abductors. And then another pattern I see is that the adductors, so the muscles on the inside of the thigh, also become quite overactive. And you can get a lot of adductor pain. Again, they're cheating in a different way for the extensors. And then the first thing that should, if it's raising your suspicion for hip dysplasia in the subjective exam, and then the objective exam, you also want to do instability testing. So there's some instability tests that can be done, looking at the patient in terms of their fear factor. So are they fearful when you do those tests? Does it feel nasty for them? Are they fearful that their hip might pop out? They don't like it. And those tend to be putting the hip in positions that kind of exacerbate their instability. So often extension and abduction. And we want to look at those as clinicians to see if that brings on the pain. There isn't one specific test that defines hip dysplasia, and that's what makes it a little bit more complex. We would also want to do the femoroacetabular impingement test, a Faddeer test. And that, again, that doesn't define whether it's FAI versus hip dysplasia. It just tells us there's a problem with the joint itself. So if those are all positive, then we would just want to get a plain X-ray as your gold standard. And sadly, what I see is that a lot of patients have had X-rays been performed once or twice or 3 times in their life. And this is where things need to improve, in that the radiologists have reported it as normal, GPs have reported it normal, other physios have read it as normal. And then you pick it up in a specialist centre that understands how to look for hip dysplasia and what the angles we're looking at. And there's frank dysplasia. I had one last week. She'd had 2 X-rays, and she had a centre edge angle at 12, and it should be anything under 25 is dysplastic. So it was very frank dysplasia, and it hadn't been picked up. So if, as a clinician, you need to get hold of the X-rays, not just take what's written on the report, and look at doing a centre edge angle. And it was one of the reasons why I put the images for a centre edge angle on the piece of paper, because it's one of the things as clinicians we talk about, but also that anyone can pick it up and just do a centre edge angle 90 degrees right in the middle of the femoral head and out to the acetabular source seal. So it's a really good thing to learn to do if you are a clinician, and look for that yourself. The thing I think that needs to improve as well is that there isn't any standardization of these angles. So if I measured it and you measured it, anyone else measured it, we might, have a variance of a few degrees in terms of those angles. So with AI, that will start to change, because we'll be able to template it and get it absolutely correct every time. So that is coming. And then with the X-ray, that just gives you a 2-dimensional image. So obviously, the acetabular coverage is 3D. So you might be uncovered at the front, you might be uncovered at the back, you might be uncovered laterally, you might have a shallower socket overall. So we want to have a look further. Imaging would be an MRI, and that would look at cartilage health. So what's the health of the joint like itself? Is this patient appropriate for hip preservation techniques because the cartilage is okay? And one of the first things that tends to happen in dysplasia, and the first time people feel symptoms, is because the labrum, which is a piece of horseshoe-shaped cartilage inside, has torn. And what happens in dysplasia is the labrum provides a negative suction in any hip. And because we've got that altered shearing going on in the joint, that labrum gets thicker and thicker and thicker, trying to help hold that hip in its place. And it's providing that negative suction, but it actually has to work 11 times harder in hip dysplasia than in a normal hip. And eventually what happens is that it just can't do it anymore and it tears. And often the first symptom that people report is that clicking, catching, giving way, locking, because the little tear is causing a problem and you get inflammation in that area. It's often between 11 and 2 o'clock, tends to be, if you think of a clock face, it tends to be in that superior, so the front top part of the socket is where the tears tend to happen. Again, that depends on your pattern of dysplasia. And then the other thing that we can do is a CT scan, and that's more for planning surgery, but also the CT scans give us a 3-dimensional image. So it really picks up the whole coverage of the joint, and we can see it, turn it on the picture, we can look at the whole coverage. And that's really useful for planning for surgery. There are, in some places, clinical graphics, which is more like AI templating, and it will literally map out the whole coverage of the hip socket and tell you where it's deficient. So whether it's deficient at the front or the back or the side, or how much coverage there is. So it should be over 70% in coverage, but not every place has that. It's quite special graphics. A lot of private places do have it, and some NHS. So diagnosis should be simple. It should be that we can pick this up quickly. If you have any suspicions, X-ray, and look at least for a lateral centre edge angle being under 25. And just make sure you check your X-rays if you're not, the one that's actually ordering it. If you can get hold of it and you can view it, it's the most important thing to do, because things are missed a lot of the time.
Okay. Can you tell us about borderline hip dysplasia and what is it?
So borderline hip dysplasia is used in the literature. Again, the research is very different. Some define it as under 18 degrees, some define it as under 20. So anything from 25 to 20 would be borderline, or in some literature, 25 to 18. Okay. Now, it means the hip's not fully normal in terms of the coverage. It is just being defined on that lateral centre edge angle. And there are many angles. I hint in the leaflet on a few other angles, but they get very complex. But the centre edge angle is only one angle to look at. And so borderline dysplasia is only being defined on that one angle. And it may be that, you could be 23 instead of 25, but that's just looking at the lateral coverage. You may be grossly dysplastic at the front or grossly dysplastic at the back, and that angle isn't capturing that. So it doesn't mean that, we don't need to worry, it's not that unstable. You can still have significant pain and instability, and it's not just, nothing to be done. But there's a lot to be discussed about borderline dysplasia in the literature. And I think, again, we need to understand and have a consensus on what the actual angle is where we're defining as the cutoff for something being borderline. And then, as I said about the clinical graphics, having those and that full understanding of the whole coverage of the socket will help us with understanding the more borderline cases grossly, just rather than just on one angle, which is what it's defined at the moment.
Okay. Are there any other hip conditions related to dysplasia?
So yes, there's a few. As I mentioned, we often see labral tears. And again, a lot of the time patients have had an MRI and the focus is on a labral tear. But the reason is, why is the labrum? So it's kind of like the elephant in the room is the hip dysplasia. Then femoroacetabular impingement. So we're finding more and more that femoroacetabular impingement, which there are two types, but you can get a little bump on the edge of the femoral neck called a cam. And that is due to an abnormal growth stress reaction, we think, during adolescence, during growth. And it just means that the femoral head doesn't become as round and it has that little bump, and that can interact and then cause impingement. And that often coexists with hip dysplasia, that little bump. And so then it's trying to work out, is it the hip dysplasia and the instability that's causing the problem, or is it the little bump that's causing the problem? Obviously, I mentioned about early arthritis, but then you've also got what we call femoral anteversion and femoral retroversion, which means that the femur itself can be turned forwards. The ball can be turned forwards, which is anteversion, or it can be turned backwards, which is retroversion. Or the socket can be the same. So the socket can be turned forwards, and that would mean you're more uncovered at the front, or the socket can be turned backwards, and it would mean you're more uncovered at the back. Okay, so those things can also affect that overall coverage of the femoral head, and they often coexist with just the hip dysplasia. Okay.
Okay. What non-surgical treatment options are there?
So there's a lot you can do non-surgically, and it is a bit of a journey, and it's learning to understand your hip dysplasia. But physiotherapy should be the first mainstay of treatment. So we want to look at getting your pain under control, pain relief, working with your GP with that. You can also have an injection. So that can be diagnostic to see if the pain's coming from inside the hip, but B, it's also a large dose of anti-inflammatory with the steroid injection that can settle down inflammation in the hip, and it can give you a window of actually being able to exercise if you're in a lot of pain. But physio itself should really focus on education and ensuring that you understand the pattern of your dysplasia. So are you anteriorly uncovered? Are you laterally uncovered? Are you posteriorly uncovered? And what are the things that will upset that hip? And if you understand the nature of your hip and you know the things that will aggravate it, which will be driven by some of those tests I mentioned in the clinical exam, looking at the strength and getting the right muscles working. But if you can do activity modifications that just de-stress that hip, and sometimes that can be, a lot of patients get pain with prolonged standing or prolonged sitting. So popping in a wedge cushion on a seat, raising the seat up so that your hips are higher than your knees will just stop any pain from the labrum and can just ease that off. If you're standing, a lot of patients stand in a sway posture, so with the hips swayed forwards, hanging off the front, and that puts a lot of load on the hip flexors, psoas, and also the labrum. So just correcting that posture and getting the alignment between the hip and the ankle, and that can be really, really beneficial for patients that have to stand for a long time. So looking at those simple things can be real wins. And also looking at gait modification, so how you walk, how you run, if it's a higher level person, or their pain is when they're running. If you're striding out and taking big strides when you're walking, then you have a big range of motion in your hip. Okay. If you're taking small little strides, leading with the knee, landing softly, your hip isn't really moving into a huge range of motion. And so you're not putting the stress through the joint as you're flexing and extending. And then if you're taking big strides, for every 2 degrees of hip extension, it's 20% of your body weight that's going through the front of that hip, where often a lot of the labral tears are, any cartilage damage, or you can get little cysts that are saying that the bone's a bit stressed. And you're putting that through a lot more stress. So shortening that stride length can really make a difference. And the same with running. If you're running, have you got the strength to run? Can you push body weight on one leg? High cadence running, so 170, 180 steps a minute, pushing them well behind you rather than striding out. That can make a huge difference to patients and the ground reaction force that's coming back at them. So education really is the key, and empowering people to make the first step, because I think a lot of the time I find that patients have come on this journey and they come to me and they've been told what they can't do. And you mustn't do this with dysplasia, you mustn't do that with dysplasia. Don't do this, it will wear your joint out. Don't do that. I don't believe in can'ts. It's how can we get you to doing it, and why can't you do it? So have you got the strength to do that activity? I might say, don't do that for the moment, but, let's look. So get you on the leg press. Can you push your body weight double leg? Can you push single leg? Oh, climbing stairs is sore. Oh, but, I can only push 20 kilos single leg, but you weigh 60. So, climbing a stair, you're pushing your body weight 60 kilos up a step, doing a squat. So you've got poor biomechanical control, your knees all over the place, your body's over here, and you haven't got that global strength through the whole lower limb. So it's not just about focusing on the lower limb. And even in those patients that are really sore, can you get them doing some low-level deep abdominal work, some BOSU work, some upper limb work, just to get some activity. And you need to try physio for at least 6 months. And we're finding more and more that it's not just about doing one thing. So having the strength training is really important, but also having the cardiovascular side and just being physically active. We found that that's really important in femoroacetabular impingement patients. And now we're seeing it in dysplasia. So if you're struggling with walking, could you cycle? If you're struggling with cycling, could you swim, for that CV side of things? Then also, it's not in the literature, but I use it a lot. There's a lot of literature out there on ligament injuries in knees and ankles, but I use a lot of proprioceptive work with my hip dysplasia patients. Again, that improves those deep hip stabilizers to work, improves the core stability, and all those little muscles that have attachments to the capsule that support the hip joint. They are the ones that need to be working, and they're the ones that provide proprioception. So you need to be able to use that, and proprioceptive work, I feel personally, as an expert, that is really important with my patients. And then it's taking them on that journey of understanding, chronic pain and managing that. There will be setbacks. There will be times where things flare. Sometimes you can explain it, sometimes you can't. But if you understand how to manage that setback, and you're building that strength and building that stability, building that mental resilience, because it is a journey. A lot of the time you've been told there's been nothing wrong with you, it's growing pains, it's something else. So hearing and being heard is really important, and then believing in yourself that you can do something to help, and you can do activity, and you can get stronger. It's just about having someone to empower you to be able to do that is really, really key. As clinicians, we should be, using outcome measures, looking at dynamometry if we can, or using strength tests like a leg press or a single leg rise test, and looking at, does that improve? Does mental health improve? So we're seeing those outcomes happen. And then I think the most important thing is also, how much can you adjust your lifestyle? Some patients really can't adapt because their job is on their feet 12 hours a day, and that's where they get most of their pain. And they can't, even the simple adjustments, no one, myself included, can hold those postural adjustments all the time. I don't remember, the shortest stride lengths all the time. So it's just working with that individual to try and enable them to be able to do it.
Okay. What kind of surgery might be suggested at treatment?
So there's a few options. First, we want to know that you are suitable for hip preservation surgery. So that's where the MRI would come in, and checking that the cartilage health is okay. There are mixed outcomes on operating on arthritis. So the main operation with frank hip dysplasia is a periacetabular osteotomy. So that's where they go in and they fracture, make 3 cuts in the pelvis, and they move the socket into a better aligned position to give you more coverage. It is a big operation. You are touch weight bearing for 6 weeks, and then you progress through and progress your weight bearing over the next 6 weeks to being fully weight bearing at 12 weeks. And then, it's 6 months to a year of rehab to get over that one. So it's a big decision for patients. But, the longevity of the PAO is really good. 70% are still with their PAO hip at 10 years. And that's increasing all the time. the aim of doing that is to try and preserve the longevity of your native socket. So we want to preserve that hip if you're in your 20s for the next 10, 20 years rather than going for a hip replacement. Okay. The other option, especially if you are a borderline case and you have some of those coexisting conditions with the femoroacetabular impingement, is considering a hip arthroscopy. And again, a lot of debate in the literature on this. So should we be scoping someone with dysplasia? If you go in and repair the labrum, and you don't solve the dysplasia, if there's frank dysplasia, the labrum would re-tear again. So it's more the borderline cases where they would suggest and consider an arthroscopy. And then, is there associated conditions like hypermobility syndromes, the Ehlers-Danlos, and caution with doing a hip scope on that, because they have to open the capsule or make little portholes. But going in and having a look with the camera, we can see what's the pattern of wear. Is this looking more of a dysplastic pattern, or is it looking more of an impingement pattern? And so the impingement pattern tends to be an outside-in pattern. So you get what we call a little carpet lesion, and it rubs up the corner of the labrum. Whereas, as I said, the hip dysplasia seems to be more of an inside-out pattern. So you get that inside tear of the labrum rather than the carpet lesion. So sometimes, we'll go in, do a scope, and we had a patient recently, borderline dysplasia with a cam, treated one side, took the cam off, it was very much impingement, went in to do the other side, and actually when we were in there, it looked much more of a dysplastic pattern. So we didn't touch and take off the cam, and we decided that we would then send her for a PAO later. And then the third option is a hip replacement. So, in advanced arthritis, we can go forward to have a hip replacement. Obviously, there is also the option of kind of watching and waiting. A hip replacement as a surgery is the most celebrated orthopedic operation we have. We have exceptional results. The hips are lasting, the prostheses are lasting longer and longer and longer. And too often in this caseload, I see, patients being told, oh, well, you can't have a hip replacement, you're too young. It's absolutely not true. It's good to have it in the hands of a, hip dysplasia specialist, but you can have a hip replacement at any age, and those hip replacements are lasting longer. So there is an argument in terms of the management that you could just wait it out if you can manage and not have the PAO, or you don't want the PAO, and you could go straight for a hip replacement because it's an exceptionally brilliant surgery. Okay. You don't want to do the hip replacement, and not many people will offer it if there's no arthritis, because it may be that it wouldn't solve your pain and the outcomes are much more mixed. So understanding the exact source of the pain is really key.
Okay. Do you advise prehabilitation?
Absolutely. So there is some research out there, and we're just doing, a colleague of mine is doing his PhD on rehabilitation in femoroacetabular impingement. But the stronger you are, the better your recovery. It's been proven in hips and knees. So lowers your complication risk. Complications come on with higher BMIs, smoking, obesity, alcohol, things like that. So the fitter and stronger you are going into something, the quicker you're going to recover coming out of it. But as I said, you should be doing, 6 months worth of physio pre any surgery in the build up. So that is your prehab, so to speak. Okay.
Do you have any other recommendations?
So I think the one thing that we can try and help with is early diagnosis and increasing and raising awareness. So if we can have that early diagnosis, clinicians, GPs, radiologists, everyone just recognizing dysplasia, we can help prevent that progression of someone leaving it too long and the joint's too far gone for hip preservation. Staying really active, low impact, doing a broad variety of exercise. So as I said, strength training with a bit of cardiovascular, with a bit of control work like ballet bar, Pilates. Yoga can sometimes aggravate because you're pushing into end of ranges, and often A, that hurts, but B, you have a lot of range. monitor your symptoms and expect ups and downs. And if you can, try and find a hip specialist, whether that be physio or orthopedic specialist, to get that correct diagnosis. And you've got certain tertiary centres around the country that really are specialist in this area.
Okay. We've got an audience question, Holly, which asks, you said physiotherapy should be a priority. What advice would you give to parents in finding a physiotherapist knowledgeable in hip dysplasia for their teen?
So I'm working on this at the moment. I'm trying to put a collection of physios together. So on my website, I have links for all the orthopedic specialists that I recommend around the country where they work privately in NHS. There aren't many of us that specialise in hip dysplasia as physios. There's a few of us around the world. But I'm working on setting that up. There is no kind of central list that says you should see this person, they are a hip dysplasia specialist. I've had people ask ChatGPT. There are hip specialist physios out there if you Google. But most of those centres, as I said, so where I've written the orthopedic specialists, because they specialise in the surgery, most of those centres will have a dedicated physio alongside them. So, you know, I used to work at Stanmore, we had a team of hip physios there. I'm now at Cambridge, we have a team there. Birmingham have a team, they offer the slightly different osteotomy. They have a team of hip physios there, Wandsbeck with AJ Malvia. So if you look at those centres, they will have a hip specialist physio in that centre. They may not be purely dedicated to dysplasia, but yeah, that would be my advice.
Okay, we've got another question as well from the audience. You mentioned proprioception training. Can you explain what it is and how you might train it?
Absolutely. So proprioception is the understanding of where your joint is in space. So if your hand's behind you, you know what position it is in because there's little receptors in all the ligaments, joints and muscles that are feeding back to your brain, saying where it is. So obviously in hip dysplasia, this is just my theory. I haven't got any paper research evidence on this, but it's what I do a lot with a lot of my patients. Getting them on the Bosu. So the Bosu is a ball that's blue on the bottom, black or flat surface. So it's half an exercise ball, if that makes sense. And just getting you standing on that. Can you stand on it double leg? Could you do an upper limb workout stood on it because it's moving all the time? Could you squat on it? Could you do a deadlift on it? And then you can progress through that. So once you're able to do the double leg work, can you do single leg work? Could you do split stance work? So could you go from a lunge with the back foot off it into a step up onto it? I use it for all the core work, so planks, side planks, you know, can you plank holding onto it? It just increases that instability, makes those deeper muscles work harder. And as I said, all those little muscles that's around the joint, they're like the natural corset to the joint. And their number one role is proprioception, okay? So if we can strengthen up those deeper muscle groups, and if we're adding that into the programs, I feel personally, clinical experience and my own personal experience, that is what has been the difference to just doing some strength training or just doing some bed exercises, you know, strengthening individual muscle groups. The whole thing has to be looked at holistically, both from, as I said, strength, cardio, proprioceptive work, whole lower limb strengthening, and, you know, mental health. It all needs to be added in to being able to use your body and then being physically active.
Okay, and we've got another audience question. I work in an MSK clinic where we see patients once in 6 to 8 weeks. Any specific protocol that you think would be ideal?
Yeah, I hear you. I understand that challenge. So I often put a strength training protocol in, and I say to my patients, you know, it is going to take 6 weeks to see significant strength changes. So if you can do things with my patients, I'll do, you know, as I said, the leg press test, build them a little program get them being able to be independent in the gym, and then I'll send them away with a program, and I progress them through double leg strengthening to step stance to single leg based on what their strength is like and where their pain is. So if they're painful on single leg activity, take them out of it, strengthen them as much as you can double leg. But that would be where I would then build it in. So I'm currently working on a whole pathway that will be used at Cambridge. But it's like the first assessment, you give them a standard home exercise program, 2 or 3 exercises. You bring them back. And then the other way that we can do it, and is what I've done with the femoroacetabular impingement patients, is bringing them into a class setting. So I've got an FAI class now where they get a 10-minute education session with then strength training and core work around, because that's the other thing I haven't mentioned is, you know, core is really, really important, and the control of that lumbopelvic area is really important. And we've seen that in FAI as well. So, you know, can they be starting to do all of that? Could you develop a class at your place where they can come in? Because one of the other things in FAI is that supervised sessions are much more beneficial than non-supervised. In an NHS setting, how do we deliver this? So I then pulled it in to be doing a 6-week class of supervised sessions, and then they go to once a month or once every 6 weekly follow-up sessions with their strength training program, and you know they're doing, you know, the technique right. So if that's a possibility. But otherwise, I would really try and, you know, identify the deficits in each of those areas. So what can they do that's cardio? Can they do that once a week? Can they do a strength training program 2 or 3 times a week where their deficits are? Can they do a core program once a week? You know, are they going to do the spinning or the swimming, or just building it up to them? And sometimes, especially with the hip dysplasias, you find that there's kind of 2 groups of patients: the super really active ones that want to do everything, and ones that actually have never set foot in the gym, never done exercise in their life, and have no interest in it. So how do you get this? One's easy. How do you get this one? So I had, you know, a girl, she was very honest. She was just like, I'm never going to do the exercises. I'm no interest. And I was like, okay, it's fair. What do you like doing? How can I get you to be active? And she said, oh, well, I used to ice skate. I like ice skating and I don't find it painful. So I was like, right, there you go. That's your physio. Go away for 6 weeks and ice skate and increase, you know, once a week, twice a week, build that up, come back and see me and tell me how many times you've done it. So the 6-week thing, I think, don't be barred by. I hope that helps a little bit.
Okay, we've got another question. My child struggles in school PE sessions. What suggestions can I make to the teacher to know when to push him and when to let him rest?
So a lot of the training that I give with my patients is understanding pain as a traffic light system. So it's okay to work in pain that's green, so your 0 to 4 pain. And if you know, depending on you and your baseline pain, your baseline may always be a 6. So if your pain is staying around the same or 1 or 2 higher, that's okay. That's your green pain. If it's going from your 4 to your 6, that's your amber pain and a little bit of a warning. And if it's higher than a 6, that's saying, you know, stop, it's too much, especially if it's lasting, you know, that night, the next day, or 2 days afterwards. So you've got to use that traffic light system, and it might be worth teaching your son that, and so that, and the teachers, so that he can then say, look, this is really aggravating me. This is, my pain's climbed up to this. And then also just not pushing to kind of ends of range. I don't know, you know, if they're doing large stretches or, you know, don't push into anything that's painful. There's lots of adjustments you can make. So if you're doing stretches where they're getting straightening the leg right out, can he just bend the knee a little bit, soften the hip so it's not in such, as I said, that strong position, and that can help him. And then just pacing it out. So instead of doing an hours of PE, can he get involved with the bits that he enjoys so that he's not left out? Because this is another thing that's really important. You know, these kids are often left out, then isolated from their friends, and can he get involved in the little bits and take a rest when he needs to, and that it's important for him. So what's the most enjoyable part for him in that PE session that he can build up to in 10 minutes, 15 minutes, 20 minutes? But could you be doing something else alongside it to get him stronger, to, you know, exactly as I've said about playing PE, he needs to be able to stand on one leg. Has he got good control? Can he push his body weight? you know, those are the things that he is doing naturally by playing PE.
Okay. Another question, are there any recommendations for everyday shoes for individuals with dysplasia and arthritis?
I don't have any specific recommendations on shoes. I'm sorry, but I would just get something, you know, it's good to go to a podiatrist and get an opinion on that. Again, if you've got like mobility, you know, you may roll over on your arch more. So if you can have a shoe with good arch support, but it's out of my remit to be, you know, recommending specific shoes.
Okay, another question, are there any physio exercises in particular that you would recommend?
I really like doing functional closed chain work. So a lot of the stuff I start people on, you know, heel raises, getting the calf complex strong is really important, because if you're weak in your calf, then you end up driving through the anterior hip to try and generate toe off. Starting, you know, Pilates based transabs work. I don't tend to like side-lying hip abductions or clams, because they can be really aggravating. And again, I find that, you know, these sorts of open chain exercises, straight leg raises, things like that, they really actually aggravate the joint. And if you look at the literature, actually those exercises are really high forces on the joint. And if you've got a joint that is unstable, it can be really aggravating. So I much prefer closed chain, feet on the floor. I do a lot of isometric glute med work. So I might do a belted sit stand, a belted bridge. But again, looking within the limits of that patient. So if they are very dysplastic anteriorly, you don't want to be pushing to extension. But the more functional, the more strength training they can do, the better. And then, you know, getting glute med and those deep external rotators going. I use a lot of slider work. So standing on one leg, using the slider to slide out into abduction or extension. But it's the standing static leg that's actually having to take the load, and you can have them in a forward lean, and then TFL is switched off. So there's examples of that on my website, and the belted work. And then I sometimes will develop that into a more advanced stage when they're on kind of single leg work or split stance work, of more ballet bar based work. So you might be moving one leg into external rotation or extension, but actually it's the standing leg that you're working in that posterolateral hip complex. And then, oh gosh, there's lots of questions coming in now. And then, yeah, just encouragement and making, I think the most patients find it so visual seeing, like, oh, I can only do 10 single leg heel raises, or oh, I can only push 20 kilos. I found that's probably the biggest win, alongside understanding their abnormality. So if they have dysplasia with, let's say, retroversion, and so they've got femoral retroversion, so they struggle to get internal rotation. Sometimes it can be as simple as, right, if I load them in external rotation, so a sumo squat versus a straight line squat, this isn't painful, this is agony. And they've spent 6 months of doing physio in all these straight line positions. And I don't actually change any of their exercises, I just change how they're loading for their anatomy. And then they're much more comfortable and they're not getting their pain. So I think understanding that patient's abnormality is the key thing, and then taking them through the strength training. The physio, what papers would you?
Yeah.
Oh gosh, there's lots of papers out there. I think the two things at the moment, the North American group have done 2 Delphi consensuses. So one is on non-operative management of hip dysplasia, and the other is on post-operative management of PAO. Obviously, that is just the North American group's input on that. But in terms of overall rehab and management, you've got the Danish group. So Julie Jacobsen, Inga Mecklenburg have written a lot of papers. And they are about to, hopefully, Lisa Tonning has just finished her PhD. So she's done a trial looking at strength training in dysplasia and whether that can prevent PAO, or strength training plus PAO. It's called Preserve Hip, so that should be coming out hopefully by the end of the year. And then Julie Jacobson is working on another trial, again in hip dysplasia, but exercises without any equipment for patients that maybe aren't suitable for hip preservation surgery for various reasons, or don't want it, or busy mums and they can't get anywhere. So that would be really interesting. I think that might come out next year. And then Mike O'Brien in Australia as well. He's just finished his PhD last year. He published a few papers, things on athletes, footballers, circus artists. Sadly, his PhD had to change a little bit because he was doing it during COVID, and so some of the things he was planning didn't quite come through. But he's got loads of interesting papers. And then we are currently working on a clinical commentary as well at the moment, which should come out somewhere within the next few months, which will kind of tackle all of these questions for physios. But there is a lot of research that needs to be done. We need a lot of consensus. We all have our different opinions as experts around the world, and we'll all do things slightly differently. So yes.
No question there.
The question is, would the foot drop make a difference to dysplasia, for example, changing the whole kinetic chain, which can further change the outcome? Could you just tell me if the patient has foot drop, or do you mean if they're weak in their calf muscles? If the patient has foot drop, obviously, yes, that can make a big difference because it's going to put a lot more stress in different areas like the knee and the hip and the back, because you haven't got that power through the calf complex to be able to do toe off. So you will end up generating some force through the front of the hip. And therefore you might get that little shear to be able to try and generate toe off. So can it change the outcome? Yes. But I'm not quite sure whether you mean the patient actually does have foot drop. So if you type again, I can answer it a little bit better.
Next question. Is it linked to DDH? For example, my daughter had surgery for DDH at 18 months old. She now has pain in her hip. She had an X-ray showing flattening of the femoral head and also some changes in the socket size. We are now waiting for an MRI. Is this common after DDH?
Yes, I'm sorry to hear she's struggling again. So yes, as I said with the first question, developmental dysplasia is what we call it from birth through to skeletal maturity. And then we just call it hip dysplasia after skeletal maturity. So sadly, some patients can have treatment as an infant, in their earlier years, and they can then develop pain later on. And it may be that, there is still some residual dysplasia. And, you can get flattening of the femoral head for various reasons. But again, it seems that, there has been some maldevelopment of the socket, and that's why there is still some residual dysplasia for your daughter. So sadly, it can be common. But an MRI will show you a little bit more about what the state of the cartilage is like, if there's a labral tear, and also they'll be looking to check if there's any what we call avascular necrosis, which can sometimes happen when they're harnessed as a baby, but the MRI will show that or not.
Okay. Final question. Hi, Holly. When should someone decide on doing the PAO?
The PAO. So it is individual decision. It's really important that, it is patient decision and it's not led by anyone. I think it's a lot of counselling from the orthopedic surgeon, having a really good medical team around you, the physio, the occupational therapist, psychologist, and parents, and the right timing. I think you have to weigh up longevity. The natural history of hip dysplasia is development of arthritis. you know, what's the age, what's the hip like, how much is it affecting your quality of life and stopping you from doing the things you want to do? How much have you seen change with doing physio? Have you really, you know, committed to it? The flip side of that is, you know, you don't want to be hammering on for years and years and years, because there are cut-offs. So they won't tend to do a PAO over the age of 40. You don't want to develop arthritis in that joint, because then they'll say, you know, you're not suitable for the PAO surgery. So it's a really difficult decision that needs to have every profession come together, and family, friends, and quality of life for you. And I think if you've given a really good go at the physio, it hasn't made any difference, and you know it's been good physio and, you know, a specialist centre, and it's failed, then very much so proceed forwards, knowing that you've got good strength and that prehab done. But it really does come down to, you know, multi-profession decision making, and no one can make it for you.
We've had a comment there to say thank you for taking the time to answer the question about my daughter. Do you have any final comments, Holly, at all?
No, just thank you very much for having me. It's been an honour, and thank you for all the amazing questions. So I hope it's been helpful, and yeah, reach out to me. I have a Hip Dysplasia Instagram, website, and there's lots of exciting things coming, and I'm working on a PAO leaflet, again, a bit like this leaflet, that kind of explains the whole process, what it is, why it happens, what you need to take. So there's more exciting things coming, and if people want to get involved and help, and, you know, everyone's passionate, having been on this journey like we all have. So yeah, love for help wherever or whenever, and ask any questions.
Thanks very much, Holly, and thanks everyone for attending, and that's everything. Thanks very much.
Night, everyone.
Bye now. Thank you.